Hi, I'm Anthony Fernandez. It's Friday, April. The Reds cruise around the world with ports of call in Asia and Europe and circling back to New Orleans due to lack of demand. So the Reds cruise around the world has been canceled. I hate to inform you, but hopefully we'll go on from there. And we have a presentation today on Cambra, on caries management by risk assessment. So thank you, first of all, for joining me, and hopefully we can have some fun together and learn some new things. As I said, Cambra is an acronym. It's Caries Management by Risk Assessment, and this is just, of course, my perspective as a clinician. And again, we have to point out that Cambra is a registered trademark of the University of California, San Francisco. So disclosures, let's get those taken care of first. I'm a private practice dentist for the last 30 years. I'm also a co-founder for a teledentistry company called newenamel.com, and for the last couple of years, we've been offering the Cambra protocol online to people remotely in the state of California. Conflict of interest, we had a small grant for the startup from Patterson Dental Supply. Other than that, I'm just practicing dentist just like the rest of you here locally here in Santa Rosa. So of course, with the COVID-19 public health emergency going on, we'll go over a couple of public service announcements. At this time, we'd like to remind you that the ADA, CDA, and the Centers for Disease Control recommend, they have recommendations to limit care to urgent or emergency dental care only. So let's please try to observe these recommendations. Essential service providers, as dentists, we're considered essential service providers. We should implement best social and physical distancing protocols and other best practices by today, April 3rd. So take a look at your office and see how the physical layout is and have things at the door so when we go back to normal, or even during this time when we're seeing emergency patients, we have some sort of guidelines to protect ourselves, our staffs, and our patients. We all want to be doing best practices for our community as healthcare providers. A big issue right now for all of us, I'm sure we're all small businesses, and this has had a tremendous financial impact. For assistance, go to the Small Business Administration, SBA.gov, Paycheck Protection Program. Check out the Economic Injury Disaster Loans and other SBA programs. My wife's home right now scrambling. You know, we have payroll, rent, all of our bills are still continuing, so let's see what we can do to get through this situation. This is definitely, as they say, unprecedented. Okay, with that out of the way, let's focus on today's subject. And this is a great quote I like to think about. It says, "Patients don't care what you know until they know that you care." The level of trust our patients put in us is something that we should always be aware of and treasure, and try to make sure that we maintain that trust with our patients. They really, they do look up to us for guidance. I have this picture of the glasses here because whenever I'm speaking about Cambra, I think about what it was like the first time I'd heard a Cambra lecture. Some of you might have heard me speak before, but this might be the first time for some of you. And I remember sitting in a room up in San Francisco, and the lecturer was John Featherstone, who went on to become the dean later on. And Cambra is really one of his life work, the body of work that he produced, and along with several other people. And I was listening to what he was saying about dentistry and this different way of looking at dentistry. It was different from how we were taught in school, and it was kind of blowing my mind. And after I was done with that and I kept learning more and more about it, it was a different perspective. So it's like somebody handed me glasses, and I really saw my profession differently ever since that time. So hopefully you'll come away with a different perspective yourself. I like to start with the why. Why Cambra? Why is this important to you as a clinician, to our patients? And what's more important than our family? The photo here is my three sons, Michael, Thomas, and Andrew. Michael's a tech worker in San Francisco. Thomas standing up by the mask there, he works out of San Francisco. They're all working remotely. They're home working. And Andrew sitting down there, the one on the left in the red t-shirt, is actually a lab tech at UCSF. He's running COVID-19 tests up on Parnassus Street. He's a lab technician at the hospital. So those are my sons. And so for me, Cambra is a personal story. My middle son, Michael, came in, and a lot of you, if you take care of your own kids, I took some bite wings on Michael. And when I looked at his radiographs, I noticed he had several proximal radiolucencies between his teeth on bite wings. I counted maybe 6 or 8 different lesions that had not been seen previous on the set of bite wings taken 2 years prior. And you know, it's when you see this, you realize, well, this person is having active dental caries. So I said, well, let's think about what we can do with the situation other than what I was taught classically. So we know as dentists, you know, when we're doing restorative dentistry, there's needles, drilling. Now in this COVID-19 situation, we have to think about the aerosols that we're kicking up. That's a high priority. And restorative dentistry definitely kicks up a lot of aerosol. Also, too, when we're cutting into teeth, we know that inherently restorations weaken teeth. I mean, we try to be conservative as best we can, but if you're going in between teeth, you're going to just inherently weaken them, and you do the filling, and the filling breaks, and that becomes a bigger filling, and if that fails, then we're looking at a crown. I call it the cycle of decay and restoration. So often if the caries are near the pulp, they've advanced, we're looking at endodontic therapy. Endo teeth crack, we all know that, they break down. Often patients just they wind up losing a tooth, and if they have the resources, they can get dental implants. That's a final option, and it's a great option. You know, I love restoring dental implants as a solution that we didn't have years ago when I was first starting. But now dental implants are amazing. But which one of us would rather be able to skip that whole procedure? There's various estimates on how much money is spent on restorative dentistry in the United States. This was from the October 2018 JADA, and then they estimated somewhere around $120 billion a year on restorative dentistry. So I thought, well, there must be a better way. So let's look at the concept of what is good dentistry, okay? What were we taught, and what are our personal views on good dentistry? This is from a great movie there. If you Google dentists are, and some of you have done this, you'll see a lot of things pop up. Dentists are crooks, dentists are evil, dentists are scams. Well, there's not a very positive outlook, perception of our profession, unfortunately. If you Google dental hygienists, they get much better search results on Google than dentists are. So, and now with, like I said, the world has changed in this COVID-19 era, so we have to really be mindful of how we are perceived as clinicians. There was an article that came out, some of you may have seen this last year, the May Atlantic, and it's a story of a perspective of dentistry, what was happening in an office here in the Bay Area down in San Jose. And this was the headline quote from the article. It says, "You likely don't need to go to the dentist every 6 months. Those microcavities might heal without a filling. And you may want a second opinion before getting that root canal." So this is the public, the popular press saying things to our patients about, hey, you may want to look into alternatives. And what they're talking about, those microcavities might heal without a filling. That's what Cambra is involved with non-restorative techniques for dental caries. So the public is just starting to get a hold of this idea. It hasn't really caught on yet, but when it does, you want to be ahead of the wave. Other good books I could recommend, Teeth by Mary Otto. And if you're a geek like I am, the history of dentistry is excellent in a book called The Long Climb, published by a dentist, and you can take a look at that later. It's a great history of our profession. So back to what is good dentistry. I'm old enough, I graduated in 1986. We were taught how to do gold foil restorations. And if you had a carious lesion, gold foiled was the gold standard indeed. We had done a few of them, and we were the first class that the state board eliminated the gold foil. So that's how long I've been in dentistry. So there's a few gold foils out there that I did back in the 80s. And of course, we were doing crowns now. You can see we've got amalgams that are, you don't see very many amalgams, but still a serviceable restoration. And for the Harry Albers fans out there, composites are currently pretty much the standard of care for restorative materials, and glass ionomers. I use a lot of glass ionomer materials, but we've got beautiful crown and bridge options. Partial still exists. Full dentures for people who are edentulous, unfortunately. What is good dentistry? We get these trade publications that come into our office, and you may look through them. Sometimes I have a different perspective on a lot of these things, but they come through and we look at them, and this cover story is better and faster root canal treatments. So if you're a patient, does that sound exciting? More dental implants, and there's also complex restorative treatment plans. I mean, don't get me wrong, what we're able to do now to restore lost teeth is phenomenal, so we're really lucky. Digital dentistry has changed the landscape, and this is the standard of care for people who've had the destruction of dental disease and are facing a lot of tooth loss, and they want to be restored. But we were taught as clinicians the importance of trying to do minimally invasive care. So minimally invasive and dentistry and minimal intervention should stand for much more than conservative cavity preparation. We were always taught, keep the prep as small as possible, but we were, some of us were taught GV black preparations for extension for prevention and that sort of thing. So there's a tug of war going on between that. So I'd like to think of a new standard for good dentistry. How about a healthy, cavity-free patient? So I decided that I want to make that my model of what is good care in my practice. So my standard is, yeah, all those things are important. Good bonding technique, excellent crown and bridge, take good impressions. Your lab has to deliver quality prostheses. And when we're doing restorative dentistry, all that still applies, but Cambra is a different way to look at it. Let's see if we could do something before that's necessary and really have healthy cavity-free patients. So in that regard, this is a great idea to think about. The main thing is to keep the main thing the main thing. So that's really what I try to focus on. I really want to try to see how I can get my patient healthy and cavity-free. Some of you may have seen an article came out about our practice last November. One of my patients is a reporter for the Press Democrat, and when I was talking to him about some things, some research that was done on our practice that summer at Delta Dental, and I'll explain that. And as I was telling him the story, he goes, wow, this is really an interesting story. You should have this. And he tipped me off to a colleague there, and they came into our office and they did an interview. And this brought a lot of positive information about our office out to the public, so that was nice. But what I'm most proud about the article was the data inside of it, and I'll zoom in on what the story was really about. So Delta Dental, I'd been working as a free consultant during last year. I would come into Delta and have conversations with them about Cambra and what its possible implications are from a dental insurance company, what this could mean to them. And they're all number crunching people. So we were talking to them, and I said, look, we have CDT codes for all these different procedures we do, and for the last several years, I've been submitting to you Carrie's risk assessment protocol, the CDT codes that I'll talk about there. We've been sending this data. Why don't you guys look at this and see if there's anything that's going on that you can pick out that's happening in our practice? So they did. So they actually hired a statistician, a biostatistician, and they called us back down to San Francisco. We had several different meetings to see, they were kind of kicking the tires on this whole concept of Cambra. And I sat in the room, and they put up these graphs. This is the first graph they started. You'll see the red line is Carrie's risk assessment of high risk. Those are people with active decay. The yellow line is going up and down. That's moderate risk. And then the green group, the green line, represents low-risk patients. A low-risk patient, by definition, has no active decay when you see them for their exam. So this study, our practice switched to a full Cambra office in about 2014. At that time, I had enough confidence to restructure how we were practicing, and they started looking at the data that far back. So in 2014, you can see the shift. What you see is the green, the low-risk group now is the majority of my patients by 2019, this last summer when they stopped the study. And the red line indicating people with active decay has gone way down. So there's a big difference. There's a big delta between no pun intended, between the low-risk group who are healthy patients and the patients with active decay. And the moderate risk kind of goes up and down depending on their balance between protective and risk factors. And we'll discuss that later. What was cool about the study, it wasn't my study, it was Delta Dental did this. It was over 450 of our patients. And what they did was they said it was kind of cool because our patients tended to be pretty stable. They didn't jump around. So they could study these patients over 4 years. So 450 subjects over 4 years. And this graph is based on the CDT codes for just doing Carrie's risk assessment. I'll show you guys how to do that later. This chart, I don't know if you can see this. This might be kind of difficult to understand, but Delta looks at all of our practices from a standpoint of they group our practices from the procedures we're doing, how many fillings, how many crowns, x-rays, prophies, everything has a CDT code, and when you group it together, as you know, there's the implant CDT codes, and there's crown and bridge CDT and operative dentistry CDT codes. They'll graph it out for your practice, and when I walked into their study, they had selected 10 or 12 dental offices at random. I don't know who they picked, so maybe some of you were in the study without being told. They just had office A, office B, office D, and they showed all the data, and what you see is a graph. This is actually my data, and I'll flip back and forth. And what you see is my CDT graphing looks different from 2013 to 14 to 15. This is when we started implementing full blast Cambra. I was actually doing it earlier. I was doing it like 2012, 2013 around the edges, and when I saw it was working, went full blast, and 2014 was full 100% Cambra-based practice. So my CDT codes look kind of strange, and you'll see there's fewer submissions for crown and bridge work and restorations, and way more of what they call the preventative care products, which are in the lower code numbers below D1000. So this is my practice over from 2014 to 2019. They gave me an aggregation of the offices in Santa Rosa that they studied as comparisons, and the data you can see it looks pretty uniform over time. There's not much change from 2014-15. The little beads at the top for all the different procedures are pretty uniform. And then the shape, they call this the violin shape. If you can see on the bottom down there, that colored area in green looks like a violin. And they said mine looks like a cello. And they use that terminology. They want violins to cellos. For them, that's an office where the patients are getting healthy, and it's mostly preventative dentistry going on and not so much restorative. So this was an aggregation of all the providers that they were studying in Santa Rosa in comparison to our practice. And they look pretty similar and are stable over time. So Delta does look at this stuff, and they're hoping to see if this is something they want to start to reimburse us for. So let's have a definition of terms. Dental caries is pretty obvious. It's what we're here talking about. CRA stands for Caries Risk Assessment. Another name for Cambra, because Cambra is a UCSF child, and also the California Dental Association put a lot of money and research into it. So the CDA published it, and it was in conjunction with UCSF and the group up there. But other universities have their own version of Cambra, and the generic term for it is called the Medical Management of Dental Caries. And in this regard, we're moving away from just being surgeons repairing a disease to people, to physicians that are diagnosing the issue and treating it medically rather than just simple surgical repair of the disease. So another term is the medical management of dental caries. A lot of this stuff is evidence-based dentistry. There's research really helps guide us and to see what's effective and what's not. Non-restorative treatments just means things that we're doing that don't involve drilling. And also what's really important about Cambra is that since we are using prescription items, and I'll get into that later, these items, because of the current way the Food and Drug Administration labels things and what you can claim and not claim, the Cambra system and the medical management as it currently exists is off-label use of prescription drugs. When asked about why this is off-label use, is that the product manufacturers, and I've been in the room when they're asked this, they said it costs too much money to go out and do the controlled studies to make the claims necessary to say, yeah, we're doing this to arrest and reverse decay. So they have to be very careful about what they say as far as the prescription goes. That's a legal issue, but not a scientific one, because there's plenty of evidence to show that remineralization is real, and what we're doing is within the scope of practice. But we have to be careful what we say, because this is off-label use of prescription drugs. This is a middle school view of how a cavity forms, and we've known this since the 1890s with W.D. Miller. This is the Cariology we were all taught back in dental school. We have sugar, fermentable carbohydrates, bacteria, they produce acids, etc. This is not new. This is in the 1890s this was published. So we've had understanding of how a cavity forms for well over a century. The term prevention has become a common language term that has been blanched and simplified to only mean brush and floss and don't eat sugar. I've had some patients come to me who were referred because of what was going on in our office, and they'll show up on my practice and they'll have, the radiographs will have a lot of active lesions going on. And I asked them, I said, hey, when you were over at XYZ office, I said, they tell you why you were getting cavities. And I remember one gal told me, she said, yeah, he says I wasn't flossing. That was the reason why, he says I don't floss enough. So he's blaming, and we often use that thing. So if you don't floss, you're going to get cavities, but that's not always the case. I have this poster up in the office here, just 1920s for Pebico toothpaste, and it was, even back then they talked about acid mouth using litmus papers and discussing how the acids were damaging our teeth. So there we were in the 1920s, pre-fluoride. the importance of caries risk assessment. Basically, in summary, this is just saying over the last several years, we really haven't moved the meter very much. Dentistry's gotten great at restoring things. We have the best restorative materials we've ever had access to, and we can do amazing things. But the disease in the background, the incidence of dental caries hasn't really improved very much since the introduction of fluoride toothpaste back in the 70s. So as a profession, there's room for improvement. So here's the JADA cover story. This is February of last year about caries risk assessment tools in oral health decision making. And what I see from this picture right now is how I long for the day where we can sit next to our patient a foot away and talk to them, and we're not wearing plastic bubbles. But we'll see what happens going forward. But this is saying the cover story was indeed about the importance of caries risk assessment and the purpose of this lecture. This photograph was taken at a CDA CARES event. I got a shout out for Dr. Graham, who's really instrumental in promoting our participation in CDA CARES event. I was at the Vallejo one, and this is the line of people who are seeking dental care. A lot of active decay out there in the public, and as you know, dental disease has been referred to as a silent epidemic by the Surgeon General. And he made that statement at the turn of this century. There's an estimated 53 million people who live with untreated tooth decay, and a quarter of adults over age 65 are edentulous. So that's definitely room for improvement. So let's get into speed Cambra. This is the best way to think about Cambra. When I was first learning it, I saw this cartoon or these illustrations, and I thought they were really helpful for how to think about it, how to rethink your brain about how to see Cambra. So when the patient comes in, we're going to do a CRA, a caries risk assessment. So we assess our patient and we say, oh, my patient has a cavity. And the cavity is represented by a nail in the tire. So we see, oh, okay, so you have an active cavity. Oh, by the way, if you see me touching my face, I Purelled before we started, so I should be in a germ-free bubble here, I hope. So, so assessment. So the first thing, a patient comes in, we assess the patient to see what the activity level is going on. The next step is to diagnose. Clearly they have a lesion, but why do they have a lesion? So we come up with a diagnosis. We say, oh, you've been diagnosed, your driveway has a lot of nails in it. You have a nail in your tire because you have a lot of risk factors. Every time you come home and you drive over all those nails, there's a good chance you're going to pick one up. So that's the diagnosis. You're assessing the risk and seeing why they have that cavity. Why is that nail in the tire? And the last step is to prescribe. Clearly the bandage is representing restorative dentistry. If that hasn't changed. If they have a cavitated lesion, we've got to fix that. So that good dentistry still applies. But what we're doing is we're taking the extra steps to instruct the patient on what to do to prevent decay and also to minimize the recurrence of decay, because if we don't change those factors, if they just keep driving up and down that driveway, they're going to keep getting nails in the tire. So that's the best way to think of Cambra. And this is courtesy of Kim Kush, who started Carie Free up in Oregon, another leading person in the caries movement. So assess, diagnose, and prescribe. When Cambra first started going, it wasn't called Cambra at that time. It was just, they were trying to think of a medical model. This CDA journals back in 2003 as when the first ideas were coming together. And the title was called Moving from Restoration Toward Prevention. And it was a two-parter. And what caught my eye about this when it came out in 2003 was Ernesto, the guy in the scrubs there. I went to school with her at UCSF. But it was a double issue, and I thought, oh, that's interesting. They have the same subject for 2 months in a row. That's pretty rare. And I threw it in the drawer and I never read it. So that's pretty, I'm sure I'm not alone. I don't read every journal. I try to read the journals, but that came, and I wish I had those. I can't even get those. They're out of print anymore. These are who my mentors are, the people that I look up to. That's Doug. I'll go from left to right. We've got Doug Young. Doug Young is the person, he was a research professor at the University of the Pacific, UOP, and Doug is a phenomenal guy, a great guy. He actually came up with the acronym for Cambra, and he's one of the lead researchers with John Featherstone, who's on the far right. The guy in the background goofing off is Brian Novi, and I'm sure a few of you have been to one of Brian Novi's lectures. Brian gives the most exciting Cambra lectures I've ever seen. Whenever Brian's lecturing, I got to be there because he's really entertaining. He's got a good sense of humor and a lot of energy. Kim Kush there, in between them, and then of course on the far side is John Featherstone, who became the dean of UCSF for the last decade and is now retired. So when when Cambra started getting on my radar personally was the October JADA came out in 2007, and it's referred to as the Bible because it has most of the findings and recommendations and treatment protocols and risk assessment. It was all kind of laid out in that one journal. If you had to read one journal on Cambra, go back online because we can get these in the CDA archives. Go back and see the October 2007 journal for Cambra. And then again, it was a double issue. And this time I did go and read it, but years later on I read it. I looked at it again and said, oh yeah, it's interesting, I should read that, it's a double issue. So I went back. So it's never too late to learn new things. An important concept, and I hit on this earlier, fillings don't stop the disease of dental caries. We really, we take great pains to do great restorative dentistry. We follow techniques, et cetera. We want to get a good bond. We want to make sure the restoration is properly adjusted and aesthetic and long lasting as possible. But when we do that, we've fixed damage, but we really haven't changed the nature of the disease for that person. That person, just because you've done a restoration, the chances of them having a cavity within the next year is phenomenally high. High-risk patients just tend to continue on having cavities. So we've got to remember, fillings don't stop the disease of dental caries. Again, there was more research done again. This is not to lay it on too thick, but October, double issue again, cover stories, 2011. Go back and take a look if you want. And then this is an article from a different perspective from a dean up at the University of Washington, Joel Berg. Although dental caries is the most prevalent infectious disease in humans, affecting 97% or more of the population in their lifetime, we primarily treat the effects of dental caries and not the disease itself. And that's what we're talking about. We want to be clinicians that treat the disease, not simply repair it. This is a great quote from Peter Milgram. Peter said, "The management of caries begins with assessing lesion activity and the potential for arrest. We want to see if we can stop the disease, arrest the decay. Teeth with lesions in the enamel or outer third of the dentin should be sealed." The outer third of the dentin, that's a pretty deep lesion by the time it's hit the dentin layer. They should be sealed and not restored, as restorations can weaken teeth and be traumatic to pulps. That's what I was trying to avoid with my son Michael. When he had all those approximal lesions, I didn't want to start carving more MODs, DOs, and yeah, I already did a few of those. You'll see on his radiographs, he had quite a few restorations, but I didn't want to just keep drilling them, and I wanted something better. So the experts continue to study and discuss a new model to treat dental caries, and this was taken, a photograph I took at a National Cambra Coalition meeting. Margarita Fontana, and you can see Peter Rushman and a lot of different people from back east and around Spain. Philip Marsh is the guy in the back. Philip Marsh is probably the world's expert on oral microbiology and what happens in our mouth as far as dental caries and periodontal disease. Really great guy to hang out and talk to. So there's the national, if you're interested and you want to seek out more information, there's the National Cambra Coalition. They meet once a year. And there's a newly formed American Academy of Cariology, and their meeting got canceled, but they also meet once a year to discuss where we're going with this whole medical model of dental caries. Year before now, this was 2018. This came out, to me, this was one of the most important journals of the American Dental Association. It came out in October 2018. And what they said was something really profound. They said they looked at evidence-based dentistry. They conducted systematic reviews and formulated evidence-based clinical recommendations for us, clinical recommendations for the arrest or reversal. That was the first time I've actually seen them use that language. I'd seen it in my own office, but for them to say, oh yeah, you can arrest lesions and reverse them of non-cavitated and cavitated dental caries using non-restorative treatments in children and adults. And I was so pleased to see that published. This is a real good one to go back and take a look at too, because there's a lot of clinical outlines there. Even if you write to the ADA, they'll send you these little cards for your office as a kind of a schematic of how to work a treatment plan. What are these prescription products? I mean, a lot of these are familiar to you. You might be using them in your office now. 5% fluoride varnish, 38% SDF, silver diamine fluoride. I've been using that since it first came out. I was actually using silver nitrate, which existed before SDF was approved. There's a lot of technique with that. If you're interested, check out any lecture by Jeremy Horst, Professor Horst, who's a really good source of information on SDF. We're using a lot of Preventive 5,000 ppm toothpaste or ClinPro or generics. 1.23 APF gels, sealants, you know, we use a different variety of modalities for treating caries. In addition to still doing fillings, you know, our patients still get cavities occasionally, just fewer. This was a great conclusion, though. This is straight off the article, the cover story. These approaches have been shown to be effective in arresting or reversing carious lesions, and clinicians are encouraged to prioritize use of these interventions. This is the ADA putting a call to action out to us to do this. This is they're saying these have been proven to be effective, and we should be doing these. To me, that was huge. So we're going to circle back now. We're winding this section up here. You can see, you know, this is just me hanging out, geeking out with the people who are my heroes. Margarita Fontana right now is really a mover and shaker. She's got some things online that you can check out. She's University of Michigan, Philip Marsh, Marcelo Arujo at this evidence-based dentistry at the American Dental Association, Doug Young, Brian Novy, and of course John Featherstone, who's considered the godfather of the Cambra protocol at my alma mater there. So if you wanted to, back in, that was 2013, there was a program you could do online and get a certificate for caries management. So I got a Cambra certificate, yay. And I also belong to the Cambra Coalition, American Academy of Cariology. So what does that mean for our office? I want to be able to give you guys some tips that you guys can do in your own practice and implement Cambra. And even just if you start thinking about it a little differently, you want to make it so it's easy to do. So what I did in 2014 was we went back and we looked at how our patient flow was for assessments when people are coming in for recall appointments. And I thought, I want to do caries risk assessment really easy. And it's really important to have your staff on board. And you don't want to make it one more thing that you do, because in the limited time we have, we want to be as effective as possible. So I looked at what we look at when somebody comes in for a checkup, and I realized this has to be part of it. I have to do a caries risk assessment along with their overall health. Look at their prescriptions, their perio status, all the usual, ortho implications, oral cancer. That doesn't go away. But when you're doing that assessment process, if it's standardized and automated, you'll want to do it, because it's not one more thing you're doing. It's just how you practice dentistry. So we put all the caries disease indicators, the risk factors, the protective factors, all there. These are what, this modifies over time as the evidence comes in, but basically it stays pretty accurate. There's been some modifications over the years as the evidence comes in. We see some things are more effective than others. But my hygienist and I, she'll check off a few of the boxes because she's talking to the patient. I come in and we hit the rest, and by the time we're done, we just literally have, this is on a paper chart, you can do it electronically, but we have all the disease indicators, risk factors. We'll have maybe 3 protective, 4 or 5 risk factors, and then we drop them into the box. You can see there's low, moderate, or high risk, and we check those. And UCSF had extreme. There's no CDT code for extreme risk, so it's only low, moderate, and high if you're submitting information. And like I said, Delta does look to see which practices are submitting those CDT codes, and they told us they see about 3% of offices, this was a while back, that are submitting CDT codes for caries risk assessment. People don't do it because typically you don't get paid to do it. It's just not how we practice typically. But we were told by John Yamamoto, who was a really great guy that was working for Delta for years, and he would be at the Cambra meetings also, and he was telling us, I don't care, just do this because we're tracking the data and we want to see this will be helpful. And this is how it was, we got graphs like we saw in our practice. So go ahead, and my front office person, Monica, will once we get that, check that box, high, low, or moderate, she'll send that out to Delta or any other insurance carrier. We also want to make it easy. I didn't want to have, we have tons of this stuff at the office. Our office varnishes, SDF, all right there, ready to go for chairside therapy. We have, if you're using prescription products, dentists have a history of not being that great about how we use prescription products. I know there's local clinicians trying to do the right thing. They just literally hand Prevident to their patients. They don't charge them for it. They're not generating a real prescription. I mean, you may record it in the chart, but you have to think about it from if a physician is writing a prescription or generating a prescription, recommending therapy, that should be recorded appropriately, and we have to be a little bit more professional about how we do that. But if you write a prescription and hand it to somebody, them going down to the pharmacy and getting the stuff, it's a barrier, and it can be expensive. The cost goes wildly depending on where you're going for 5,000 ppm toothpaste. chlorhexidine, et cetera. So we try to keep it here. We do what's called the direct-to-patient dispensing model. There's a CDT code for that as well. So we literally, after we have the treatment plan, we hand them printed instructions. Monica reaches over and grabs the products. We put them in a bag and say, here's your therapy. You're going to go home. And they've been instructed on how to use the products appropriately. So we try to keep it simple and easy to do. So it's real caries management by risk assessment. And that's just how we do it at our office. So let's go back to wrap up the reason why, return to the reason why I do Cambra and why we should consider doing this for all of our patients. So there's a sign in my waiting room there that says we follow Cambra for the best in preventive care. Patients love it. My patients, they really get it now, and they can feel the difference, and they know that that we have their health is priority for us. It's they know that we're trying to keep them as healthy as possible. And they appreciate that. So the patients really like it. When the staff understands the objectives, and we do, it takes a little while to kind of get everybody on board, but my office is phenomenal now. Monica and my hygienist, I can be walking down the hallway, and Christina, who is at home now because all of our hygienists are idle, she would be doing the caries risk assessment, asking all the correct questions and getting the information before I even walked into the room. And when it's a team effort, it makes it a lot of fun, and there's a lot of morale boost knowing that we're doing our best to keep our patients healthy. And finally, for why I started getting into this, my son Michael's had great dental health since that time. I stopped drilling him, and his lesions did remineralize, so I didn't have to go back and continue to carve off chunks of his marginal ridges. So that's why it's, for me, it's a personal thing, but it's been very rewarding. I've had more fun the last 10 years of dentistry than I did the first 20. Financial impact. It has had an impact. Cambra, when you have fewer crowns and fewer restorations, that's a bottom line hit. We have way more, we make it up in other ways. We have, people still crack teeth, and I'm still sending stuff out to the lab. And with patients, there's a lot of things that are going. We replace things that are broken or cracked or things like that. But yeah, you can actually, it does have a hit on you, but you tend to generate a lot of, I have no advertising budget. We get new patients by referral, word of mouth. People get what's going on, and they're naturally drawn to the office. So if Cambra is so great, why isn't it the standard of care? Schools are teaching, the vast majority of dental schools teach caries risk assessment, and there's all kinds of, what we're taught. There's legal, there's tort actions that are part of the standard of care. I've been told that it's very rare for a dental office to be sued for not doing Cambra, but it does get included into lawsuits. Ed Zinman, who's familiar to a lot of you as an attorney that practices here in Northern California, he's at these Cambra meetings and he's taking notes, and I found out that, yes indeed, when he's taking litigation against a dentist, they'll see if they were doing caries risk assessment, and if not, they tack that on to some of the things that go down. So Cambra usually, it shows up in court, and they'll say, hey, your own profession's been telling this for the last several years, and yet here you are, you have no caries risk assessment, but a lot of restorations going on, what's up? So it's eventually, it does filter down, but let's try to see if we can raise the standard of care and not have to be pressured in through litigation. Let's just try to do what's the right thing. When I go to a Cambra lecture, typically, this was at a CDA conference, it looks like this. There's not a lot of people in the room, some old retired people and some dental hygienists who are interested in the subject, but if this is a symposium on full mouth reconstruction, the room's packed, but Cambra is not as popular as I think it should be. So here's the CDA journal cover story, most recent one that covered it. This is the latest information where they were publishing results from the most recent study that was done here in Northern California over several years. Here's what I was saying earlier. When you look at the different risk factors, low risk, moderate, high, and extreme, if you're a low risk patient, UCSF saw that even within a year, even almost 24% of those patients went on to have an active cavity within the next year anyway. Now, I don't see that in my practice, but this was a university study, and their population group might have been different than what we see in our private offices. Our low-risk groups, as you saw from that graph, they tend to stay low. We still see some active caries on the patients that you recognize, the ones that, I'm not sure if they're brushing at all, and their dietary changes may have not been very effective, so they still see some cavities, but I don't see anywhere near 24%, but that's what the research said. Moderate risk, they're kind of in the middle there. And high risk, the people who are actually coming in with cavities, you see from that data, it's almost 70% of those people go on to have a cavity within the next year. And extreme risk, well, that's just sort of off the chart. So how effective? So here's that study I was referencing. I was actually in this study when it started, but we had to drop out because our patients were already doing Cambra, so it wasn't appropriate for us to continue. This data, if you have the original in your house, the chart was messed up. CDA published it incorrectly, and you have to go get a supplemental one because they messed up the lines. But you can see the group at the top, the control group. They were given, how it worked was your patients came in, we did assessments, and there was a black bag and a white bag with different therapeutics, and they didn't tell us which ones had the actual prescription products and the other ones were placebos. And over time, they were studying your patients, and they were looking to see the number of restorations. It was really quite detailed. And from what you see in the study, which is kind of interesting, there is a delta between the intervention group, which received the real prescription products, and the control group, which still had fluoride toothpaste. You can't, it's unethical to do a human trial study without having access to fluoride toothpaste. That's considered inappropriate. You can't deny people fluoride because the evidence is so great that that's actually harmful. So they got just regular over-the-counter fluoride toothpaste. And so there is a change, 75 high-risk patients had no active cavities after 2 years. And as we see before, without intervention, their chance of having a cavity is almost 70%. So there was a huge drop-off with the patients that had, there was a massive improvement for the people who received the prescription products. The control group, what was confounding the researchers, Ben Chafee and Peter Rushman, was why was there such a great improvement in the control group? You think the control group should just be straight across, but what they didn't take into consideration, and I had to point this out to Peter, is 40% of our patients brush once a day. So if you're brushing once a day, that doubles your caries risk. And in this study, they had to brush twice a day, and they had to follow the protocol more detailed. So you're going to see an improvement. Even if you just tell people, don't brush once a day, brush twice a day, and they were following the same instructions, which was probably an improvement over their traditional hygiene practices. Of course, the control group's going to see improvement too, because like I said, 40% of those people were probably only brushing once a day. Now for the study, they had to brush twice a day, so you're going to see an improvement. And they said, oh yeah, so, but that's why the change. But it does show there is a change between the control group and the treatment group. Cambra is not about perio. Perio is perio. That's, it's a different disease. There's still microbiology involved. So the thing to remember is that you want to coordinate periotherapy and Cambra. They work great together. So when the patients are doing all their mechanical hygiene practices, you want to make sure that doesn't interfere with the remineralization, because we're trying to teach our patients, yeah, we want you to clean your teeth, but we want you to also to remineralize. That's the thing that we're teaching people, is how to remineralize. So this is kind of humorous. Dentist stabs your gums 20 times and you bleed. So, and if you brush more, you wouldn't be bleeding. This is how patients, they see us like that. Essential concepts of the Cambra system. So the original model was a balance. This is the most recent model. They kind of simplified it. So you've got this teeter-totter going. On one side, you have no caries. You have a healthy patient. On the other side, you have people with active decay. So the disease indicators and the biologic risk factors, and we'll go over those, are on one side. That's tipping the scale. We want to maximize those protective factors. This is an older, complicated one. Let's go to this here. So dental caries, as we know, is a multifactorial disease. So we're going to assess the factors. Let's go back and look at what causes tooth decay. In my office, for the patients, it's important that we understand, my staff understands cariology, but our patients, we try to give them a model to think about as they're taking care of their teeth. We like to use this model here. It's just on our computers at our office, and we call it the tug of war. So there is a tug of war between the bacteria, your dental plaque, and the oral microbiome, and their diet, the sugars and fermentable starches. That's the demineralization side. Then, of course, we have remineralization, and we've got saliva and fluoride, which are our ability to remineralize. And I tell patients, our teeth have an amazing ability to repair themselves. It's just that our natural defenses are sometimes overwhelmed with the bacteria in our mouth and what we're eating, and that's why we have tooth decay. So it's a controllable disease, and if we manage ourselves properly, you can actually repair your teeth without having me have to drill on them. And the patient, that gets their attention. They're really receptive to that message. I'm going to go back. Let's see. This is available if you go from Dr. Fontana generated this. This is on the internet as if you Google, I have a cavity, just write, I have a cavity, then put the initials NIH, National Institute of Health, and all that information is available for free. It's a great screensaver, so it really helps while we're having our talk with our patient, because we want to be able to do this quickly in the office. We want to get a really good mental image in their mind so they understand the objectives. Cariology Fundamentals, let's go through this pretty quickly. So we know teeth are the hardest substance in the human body. We can dig up a skull from centuries ago, and the teeth are the best preserved part of the body. So why is it we can't keep them going while we're alive just for the few decades that we're here on this earth? Mostly 96% minerals, so teeth are basically rocks with water and other organic materials. And we all know this is going back, teeth, we call it hydroxyapatite is the mineral. It's a mixture of calcium and phosphate, and it's not a pure HA. It's not a pure hydroxyapatite. It's a mixed apatite because we'll have other things mixed in there like carbonate and other items. The OH ion can be replaced by carbonate or fluoride. It's the structure of our tooth is variable. I'll explain why that's important. Hydroxyl groups can be substituted. When teeth erupt, like in children, they have a high levels of carbonate. So when we're young, people have been told, oh, why do I get more cavities? And the dentist frequently tells them, well, you get cavities because you have soft teeth. Well, it turns out we all have soft teeth. When we're young, there's a higher percentage of carbonate in the crystal, and over time that carbonate is displaced and the hydroxyl groups plug into the structure and make our teeth more acid resistant. The critical pH for enamel is generally accepted to be 5.5. The critical pH being at what pH do our teeth start to dissolve, start to break down. And this is really important. I'll explain why. Fluorapatite has a critical pH of 4.5, and we know that this scale is logarithmic. It's like an earthquake scale. If you get a 6-point-something earthquake, you're going to get a pretty good shake. If you have a 7-point earthquake, your building's coming down. It's orders of magnitude greater. So the critical pH between fluorapatite and mixed apatite is a big deal, going from 5.5 down to 4.5. A little bit of chemistry. You see mostly the calcium and phosphate groups around that little center hydroxyl group, and that's right here. This is where the hydroxyl groups plug in, or you can put a fluoride in there or a carbonate. We've seen these in different advertisements for remineralization, teeth that are demineralized and teeth that are highly mineralized. So we want to play with the surface. As a Cambra dentist, this is your canvas. This is where you're working. I'm going to summarize this just by saying the important thing to remember with sugars is just not how much sugar you're taking. And the sugar, of course, the frequency is everything. It's how often you're taking it. But you're also affecting the bacteria. So the more frequent somebody ingests starches and sugars, you change the population spectrum of what type of plaque they have. So controlling plaque, it isn't just a matter of taking and floss and using an electric toothbrush. Yeah, it's mechanical removal. But what type of biology you have in the patient's mouth is dictated by the frequency of the sugar intake. The populations will move depending on what their diet is. How's the acids attack our teeth? So Doug Young lectured here in Road Empire Dental Society a couple years back, and he was getting this point across, and I thought I'd add some illustrations to help improve on that message. So acid-producing bacteria are on the outside of the teeth. They're in the biofilm. So they're standing on the surface producing those acids. So imagine you're standing at the beach, and when you stand on the sand, you don't fall through. But yet the organic acids that are produced by the plaque penetrate into the enamel through diffusion channels. So there's all these columns of crystals, and as the acids, acetic acid and all these different inorganic acids, they percolate through the diffusion channels, lactic acid, acetic, propionic acid, and that goes into the tooth, weakening the tooth inside. And as you remember on the tug of war, I talk about saliva. Saliva, here, I'm just going to let's bring these all up. These are all the things that saliva do for us. They have buffering capacity. Your saliva has electrolytes, antibacterials, there's enzymes. We produce about 1 liter a day if you're healthy. There's a phenomenal bicarbonate buffering system, so when there's changes in the pH, after you eat a meal with starches, the pH will drop, typically somewhere around a pH of about 4. But then your saliva, natural saliva flow will push away the food particles and it buffers the acids. And when the pH comes back up, it stops that demineralization process. The saliva is supersaturated with calcium and phosphate. So the two main building blocks of our enamel are supersaturated in saliva. So when when the pH is in the correct range, the saliva is repairing the surface of our teeth for us. That's super important to understand why saliva is so important to dental health. There's all these different enzymes involved, but just understand saliva if we're going to be doing this correctly. So I tell patients, I say it's important that patients understand that their saliva is very important to your dental health. And I always use this line, I tell this frequently, I tell my patients their saliva is their real dentist and I'm just the pothole repair guy. And that's true, because if you have a patient who has a salivary problem, that's a real challenge. It's really hard to get good caries arrest and control when somebody who's hyposalivary. This is not something, you've seen this probably when you took classes in Cariology about the Stephan curve. So you see here at the top of the graph, you've got a pH of 7. Neutral pH, and during the day when we ingest sugars and starches, we have that dip in pH. There's breakfast, lunch, you might have a snack or a soda pop, there's dinner, some more snacking. There's a lot of snacking going on these days. And the critical pH, you see that 5.5 line. So every time the pH drops below that red line, that's demineralization. You get enough area under that curve and you're going to see active dental caries. But now imagine, like I said earlier, the critical pH for fluorapatite is 4.5. So now that new red line, you can see that if the more percentage of the tooth that you're able to have as fluorapatite, you've substituted the hydroxyl group and the carbonate for a fluoride component in the apatite crystal, the critical pH now for those portions of the tooth are at 4.5. So you see very little area where it's possible to generate caries. Now, doing Cambra, we can't convert the entire patient's tooth to fluorapatite, but we can get a high percentage of that to change. And you can actually see that in, with evidence of microscopic evidence of the inclusion of the fluoride into the surface of the tooth. It's very complex, but the more fluoride you have present in the patient's mouth, you get that advantage if you see the Stephan curve. I always thought this is a great way to represent what we're doing. We're treating the disease and we're lowering the threshold for the damage. What's important, what I didn't know prior to this, was that the bacteria usually shut off at about a pH of 4. Once the plaque hits a pH of 4, they're done. They stop making the propionic acid and lactic acid, the acetic acid. They're kind of finished. A lot of foods we eat have a pH much greater than that. People who like lemon in their water, or they're drinking white wine and things, those pHs are way down, even way below 4. So there's a lot of acid challenges to our teeth other than just simple microbiology producing these acids during food ingestion. So our teeth are constantly getting hit with acids, and we want to make sure that we're remineralizing effectively. I would listen to, during this the COVID emergency, people are snacking more. Oreo sales are really up. People are home and just kind of stress eating right now. So something to consider when we get back to work. A little bit about fluoride. If we're going to be doctors of the mouth and understand this, if we're prescribing this product in various different forms, we should have a pretty good understanding of what fluoride's all about. Some of the patients who are really into it, I show them, look, if they're into natural cures, there's nothing more natural than an element. Fluoride's there right on the periodic table right next to oxygen. It's the 13th most abundant element on Earth. So here's the big 4 things that fluoride does. This is why fluoride's so important to treating dental caries. Fluoride promotes remineralization by catalyzing calcium and phosphate diffusion into the tooth surface. It's a fancy way of saying the fluoride helps speed up that remineralization. Second, fluoride inhibits demineralization. There's a really strong bond between calcium and fluoride. Fluoride is the most electronegative element on Earth. It has a really strong negative charge, and when it grabs onto calcium, it doesn't want to let go. So it inhibits demineralization. That's how you get that shift in the dissociation pH. Fluoride inhibits bacterial enzyme activity, including strep mutans. So just having fluoride ions floating in the oral environment, it inhibits the normal function of strep mutans, and it stops them from producing as much acid as they normally do. And the fourth is fluoride is persistent in the oral environment. It's locked into glass ionomer materials, it's locked into tissue, and it floats around in there. It's retained in the intraoral reservoirs and released into the saliva over time. So fluoride is helpful because it's not a one-shot deal. It tends to stay around in the oral environment. So there's 4 things that fluoride does to help us fight tooth decay. If we're going to be prescribing fluoride, we should have an understanding of what dosage are recommended, because we don't want to just throw a ton of fluoride out there. We have to be physicians and understand doses. This is from the U.S. Institute of Medicine, the IOM, and they have estimates for the daily intake. Adult males, I would start with women who are pregnant and lactating, about 3 milligrams a day of fluoride. This is intake. This is not topical use. This is like actual ingestion. Men, 4 milligrams a day, and kids from 1 to 18, it's stepped up from 0.7 to 0.3 milligrams a day. This is actually swallowing fluoride, not rubbing it on your teeth and spitting out topical use. Currently, there's no daily value for the intake level, so it's not required to be shown on food labels. If you want to get into the math of fluoride, Colgate, I don't know if they still have this. This was available online. They had a fluoride conversion chart, so you could just sit there and plug in different amounts of things and calculate what the dose of fluoride is. So it's a handy chart that you could use. Yay, fun. But it's important if we understand how much fluoride we're recommending and keep it in a safe zone. As you know, soluble fluoride salt, sodium fluoride, is toxic when you ingest it, so you can accidentally eat a lot of fluoride and get sick. That is indeed true. The lethal dose, you got to ingest, like just sit down there and pound down between 5 to 10 grams. That's a lot of fluoride before you have what's considered an LD50 dose. The lowest recorded dose is 4 grams, that somebody took 4 grams and that was it. But somebody survived a dose of 120 grams of fluoride. I don't know who would take in 120 grams of fluoride. Mostly you just treat it with calcium because of that strong affiliation between calcium. If somebody ingests a lot of fluoride and they get that upset stomach, the most common advice is just drink some milk and you'll feel fine. But we do have to be careful. We just don't want to throw it around willy-nilly. US dietary reference intakes, again, let's review that. Adults, about 10 milligrams of fluoride a day. That's the equivalent of drinking 10 liters of fluoridated water. We don't have to worry about that here. Our water's not fluoridated. Santa Rosa does have fluoride in the water, as almost all natural sources of water on Earth have fluoride. It's hard to find water on planet Earth that doesn't have some fluoride in it, but it's just not very high. So you have to drink about 10 liters of fluoridated water to do that, to get to that 10 milligrams. And infants, it's down to 0.7 milligrams. So you can make a baby bottle up with fluoridated water and it's not going to be, it's still in the range of what's safe. This is just talking more about fluoride safety. I mean, the biggest thing from a practical standpoint, there's not a lot of people, I mean, I've never heard of somebody dying from fluoride toxicity, but the thing that you do have to be careful is mild fluorosis. So, and that, how you see that, it says don't eat toothpaste, and I'll explain that in a minute, because I've seen some local fluorosis in patients, and like I said, we have a non-fluoridated community, so where's the fluorosis coming from? No reputable health organization opposes the proper use of fluoride to treat dental caries. So it's, like we said earlier, you can't do a human caries study and deny somebody fluoride. It's just considered non-professional. Let's see, here we go, fluorosis. So I was wondering why, I would see occasionally a patient would come in and we'd see some mild fluorosis, and I'm like, wait a minute, this patient was born and raised here in Santa Rosa. They've never lived outside our community. Why is this person here with fluorosis? So I'd look back and I started asking, we talked to other clinicians about this, and typically they think it's kids eat toothpaste. And I actually started asking some of my patients, and when they get to be about 10 or 12, if you have a good rapport with them, rapport with your patients, they'll be pretty honest. And they've told me, like, yeah, when I was a kid, I would eat the toothpaste, and it has to be ingested while the teeth are forming. Once your teeth are fully formed, eating fluoride will not cause fluorosis. That has to be happening. You have to ingest the fluoride while the tooth is forming. And they were like, oh yeah, I would full on just like suck on the tube, and it just sounds kind of strange, but I found out more people eat toothpaste than I had thought. So that if you see some mild fluorosis, it's usually mild. Just ask them about that. There's a lot of fluorosis depending on where somebody's, I have patients that come from other countries where the water might not be tested properly. You're not supposed to ingest water above 3 or 4 parts per million fluoride because you'll see some fluorosis in the dentition. There's a lot of fluorosis. I'm just going to skip ahead here. Okay, so here we go. In summary, fluorosis is easy to avoid. Kids, don't eat toothpaste. That's the best way to think about that. And if you're on a well, you may want to have the well tested too to see what the level of fluoride. It's hardly, you don't see a lot of fluorosis in this region, but in parts of Texas and Southwest, there's a lot of fluoride in natural groundwater. So the main thing is locally, just don't eat the toothpaste. And like I said, it does not happen in erupted teeth. Once your adult teeth have erupted, you don't get fluorosis. Okay, so what we like to show patients is we recommend supervised brushing, and this little diagram shows as soon as the first tooth erupts. Now, this is the current best practices that we're supposed to share with our patients. And we have a little diagram in our office to show them the rice grain or smear. So as soon as a tooth erupts, get some fluoride toothpaste. Usually the kids' flavors are better. The little kids tend not to like mint very much. And you put a little smear on there, and they do that up until age 3. That's the appropriate amount because kids can't spit very well. Once they get to age 3, they go to a pea-sized amount. And to be honest, that's pretty much what I use. I use about a little blob about the size of a large pea on my toothbrush, and that's usually sufficient to get the job done. So once they hit age 3, you go to that size. I took this picture up at the county offices during the water fluoridation debates. This was a great poster. Fluoride is a poison. Let's not drink it. So, all right, let's not drink it, but let's use it topically and spit it out and see what we can accomplish. A lot of people are really afraid of fluoride, so let's talk about that a little bit. This is this COVID environment now where the fear is really important, and so the fear of fluoride goes way back. Fear is important to our survival. People like to tell people something because they think they're helping somebody. So if they think they've got some information, they want to pass it along, and that feels good giving somebody else information, even if it's negative, because it's empowering to give other people a warning. So a lot of times people say all kinds of crazy stuff. I'm hearing it now with the virus out there as well. Sharing our fears with others brings us comfort and a sense of purpose. We feel we are doing the right thing, and so that's whether it's vaccinations, water fluoridation, things like that. That fear really travels quickly. I tend not to argue. It's counterproductive to argue with somebody who's already afraid of fluoride, because you don't want to feel, you don't want to give people a sense of shame or guilt. What I do ask is if they do decline the therapy we recommend, which happens, not everybody wants to use 5,000 ppm toothpaste or even varnishes. I enter it into their treatment record and have them sign it that we recommended the therapy and they're declining it. And then the best advice I can offer is that patients treat sugar like they're allergic to it. So let's see what the latest with Cambra in action is. Now let's go to the last journal that came out last year. As I just said earlier, Cambra is divided into 2 groups. There's everybody under age 6, so from 0 to 5, and the adults. And a Cambra adult starts at age 6. And the biggest reason why they do this is people under age 6 just can't expectorate. They can't spit out effectively. And anybody's got kids at home, they know this. The first time when my kids were brushing their teeth, we're at the sink and we're supervising them, and I said, okay, now spit your toothpaste out. And they just go, and nothing really comes out very effectively. Then they ingest it. I'm like, well, that was, I had to try do a mental calculation of how much fluoride they just ingested. So I wasn't really giving my kids the fluoride supplements. I figured they were eating enough in the toothpaste to be adequate. And in general, I know Michael, the middle one there, the one on the far side, he had a few cavities, but it was more dietary related. But other kids have pretty good teeth. They didn't get too many cavities. So that's the great divide. So let's start with the adults here. We're going to start with people over age 6. So again, we're using the most current model for the Cambra model. There's the tug of war, but UC tends to use the teeter-totter method. There's disease indicators, and these are the 3 important things to know. Disease indicators, biologic risk factors, and the protective factors. So when you're doing caries risk assessment, these are the things to consider. Number 1, we're focusing on the disease indicators. Number 1, new cavities or lesions into the dentin radiographically. You look on there and you see like an old state board lesion in there. That enamel's dark. You can see a radiographic evidence of caries. If you see cavitation, well, for sure, yeah, you see a cavity. If you look in a patient's mouth and you see cavities, it's pretty obvious. We all know what a cavity looks like. But we want to be a little more refined than that. So number 2, a new active white spot lesion on smooth surface. An active white spot lesion is different than fluorosis. There's a lot of things that cause white spots on the teeth to appear, but in this regard, this lesion, the best way to tell the difference between a white spot lesion and fluorosis is you just take your air syringe and gently dry the surface of the tooth, and you look to see, is it shiny or is it matte? Is it kind of flat color? If it's flat, matte colored surface white spot, that's an active lesion. That's the first stage of that demineralization that's evident, and we've seen those. Especially class 5 around the cervicals of the teeth. So that's something to watch for. Now, if it remineralizes and becomes shiny, that's an arrested lesion. That's different. But we want to see, if you see a patient come in and you see these white spot lesions, and we've looked at enough teeth, you know what I'm talking about. You've seen those. new non-cavitated lesions in enamel that are on a bite wing radiographically. So just like my son Michael, we took x-rays, we looked, and there's all these little dark spots in between at the contact areas. That's disease indicator number 3. And the last one is existing restorations done in the last 3 years, if it's a new patient, or within the last year if it's a patient of record. Meaning that if somebody comes into your office and you ask them, say, have you had any fillings or restorations done for tooth decay in the last 3 years, if they check that box, that means de facto that they have a positive disease indicator. If it's one of your patients and they come in and they've got a brand new cavity, yeah, now they're not low risk anymore. They're automatically, they bump up into high risk. So decay activity, this is super important, I'm going to say this. Decay activity is the greatest predictor of future decay. So you're really watching what's happening in your patient's mouth. If they're cavity-free, they continue to be cavity-free over and over and over again, you see the trend that's going on with that patient. But the patients who are having active decay, you really want to focus in and look at the disease indicators and then go on to the risk factors. So again, in review, for a new patient, one or more of any of those disease indicators is a high-risk patient. As soon as you take new x-rays, new bite wings, or you see a cavitated lesion, automatically a high-risk patient. Your risk assessment, it's not done, but you know automatically what their risk level is, and you're just going to fill in the details as you go on. For a patient of record, any new disease indicator is high risk. Like my son Michael, he came in, the bite wings were different. And those are actually, yeah, those are Michael's bite wings right there. You can see he's had some DOs and things already, but those other lesions were brand new. So that was indication of high risk. If high risk and hyposalivation or low saliva flow is present, that's extreme risk. So I keep track of that at our office. Usually extreme risk patients, you know them, they're the older patients, they got super dry mouth, they'll have multiple caries, lesions, very dry mouth, their saliva flow is compromised. So that's an extreme risk. There's no CDT code for it, but we record it anyway using classic Cambra. Even if there's no active disease indicators, the patient can still be high risk if the risk factors outweigh the protective factors and hyposalivation continues. Meaning, think of that teeter-totter. If a patient, just because they don't have a cavitated lesion or their bite wings look okay, if they've got a ton of risk factors and not many protective factors, you can still consider them high risk even though they're lacking an actual cavitated lesion. And that's been changed recently. That's a new development. After assessing the disease indicators, you're going to go on to the risk factors. We're going to go back. This is looking at the driveway now. Why is this patient coming in with cavities? So we're going to look at the driveway, as we said. This is straight out of that new journal. The first one here is the risk factors are evidence-based. These are things, they did a lot of, how UC came up with Cambra was they looked at 12,000 patients, and I would take Featherstone John out to dinner and just poke his brain and talk to Doug Young. And they looked at flossing, they looked at electric toothbrushes, they looked at Listerine. There was all these things that we always thought were important in dentistry, and they picked a big random study and they subjected them to really good statistical analysis. And so things like flossing didn't make the cut. It turned out a lot of patients, it didn't matter if you're flossing once a day or twice a day or at all. It didn't show up in the data. So what they're looking for, this first item in the most current CDA journal about doing caries risk assessment, they're asking for a test to see quantitative bacterial test. This doesn't exist yet. They put it in there knowing that we really don't have a way to test for the biology. Like we're all looking, we've got this COVID virus that we came up with a test, and we have rapid testing and all these new things. You want to see the virus right away. We don't have a caries test because it's a multifactorial disease. It's not just strep mutans. There's 30 different bacteria that have been identified as producing caries. So we don't have a really practical way to measure caries activity yet. So the risk factor number 1 doesn't exist. We can't really give our patients a test. Cari-free, Dr. Kush's company did have this machine for a while, and we experimented with this in our office. It was a swab that measured ATP activity in the biofilm. You would take when the patients would come in, you'd swab their teeth, you drop in this little capsule, and that machine would identify bacterial activity. And if a patient was really plaquey, it would generate a score, and we would record that. We stopped doing it because over time the evidence dropped out for its efficacy, and it was kind of expensive to do, but it was interesting. It did match. If you saw somebody who was really plaquey just using their eyes, we would guess how high their number would be on the machine. It was kind of fun, but this system kind of fell by the wayside. But Doug Young really believes there's some value to ATP testing. But currently this is not recommended. Number 2, heavy plaque on the teeth. Anybody can do this. When your patient comes in, and we all have seen patients where we look in their mouth and they're just really just coated with visible plaque. They don't get that's the risk factor is heavy plaque on teeth. They don't get complicated. They don't say in this location or that area or it's real thick or what. They just say if you look in the patient's mouth and you see heavy plaque, that's a risk factor. Just check the box. And there's all the studies that are related to that. Frequent snacking. This is a big one. I really try to teach my patients. It's not that they should never eat sugar. Yeah, if you're not doing any fluoride, yeah, you better really treat sugar like you're allergic to it. But I've got a sweet tooth. I'm eating jelly beans here to keep my blood sugar up while we're doing this. So frequent snacking on fermentable carbohydrates, if you can do it 3 times a day, and this is where Philip Marsh's research was so brilliant, the bacteria tend to stay stable if the sugar is in it frequently. If you take it in the morning and then several hours, maybe 7 to 8 hours go by, then another hit of sugar, and then again, maybe after dessert at night, the biofilm tend to stay stable. But if a person is snacking frequently, and the magic number that the research said was 3 times, if you're doing more than breakfast, lunch, and dinner, then you see a change in the biofilm. You get acidogenic bacteria that produce acids much better, and you get acidouric bacteria that tolerate a high acid environment. So you're changing the biofilm again by the diet. So we tell our patients, look, you can have pancake syrup on your pancakes, and you can have peanut butter and jelly at lunch, and you can have dessert at night. If you cut out the in-between snacks and you're not doing sugar all day, that's really where you can make an impact. So the patients, you give them alternatives, nuts, cheese, proteins, vegetable, those are all things. So we try to keep the instructions as far as dietary recommendations, keep it simple. Sugar consumed more than 3 times a day alters the cariogenic nature of the oral microbiome. With frequent sugar, there is a population shift that favors acid-loving and acid-producing bacteria. And that's it. So frequent sugar intake, you have an impaired microbiota, you get what's called a dysbiosis, and you get dental cavities. This is a really great way to think about how sugar impacts the disease of dental caries. So think about controlling the biome with the diet, not just with a piece of string. Not to get down on flossing, but Doug Young had a great line to me when I was kind of learning about understanding what Cambra was. And Doug goes, think of a disease. Let's say you have an ear infection and you go to your doctor with an ear infection. And you got inflammation and pain, and the doctor looks in there and takes a culture and says, oh yeah, you have an ear infection. Here's a piece of string, go rub it on your ear. You would think the doctor is nuts because that doesn't seem very effective at all. And yet that's basically what we're telling our patients to do is just go rub some string on there. And there's some studies that show effective flossing does indeed lower the quantity of bacteria. But the problem is most people aren't effective at flossing. You can use flossing to help reduce caries, but in the real world, it's not very practical. And the data supported that in multiple studies. People just can't floss well enough to make an impact, so we don't beat them up if they're not flossing correctly. We try to encourage that for periodontal disease, et cetera. We don't tell them not to floss. We should tell them, do good mechanical hygiene, but you have to understand it's got to be paired with remineralization to really make a dent in dental caries. Hyposalivary medications. Xerostomia is a side effect of some of the most common over-the-counter and prescription medications. The risk of dry mouth increases with the number of medications prescribed. We all have patients that come into our office as they get older. They tend to check off multiple medications. That's why you want to have a good health history when you start. You'll look to see if they're taking blood pressure medications, anti-inflammatories, antihistamines. There's over 500 different medications that can have the side effect of dry mouth. Like I said, antihistamines, antidepressants. If patients are taking SSRIs like Zoloft or Paxil, diuretics, sedatives, decongestants, all kinds of stuff, even anti-inflammatories like ibuprofen. Those are all things that can depress salivary function and flow. We keep a list because we can't, usually you do this enough, you kind of understand, oh yeah, if they're taking certain blood pressure pills and stuff, you just check the box right away for the assessment process. But we keep these in our office to quickly look up what medications have the side effect listed for dry mouth. Or you can just use the PDR, but that takes a long time. You want to, like I said, you want to get Cambra assessment easy to do. And if you keep these in your hygiene room where you do your recall exams, we'll go back and look it up to see real quick if there's a medication that's on this list. You can get this for free, the one on the right from Carie Free. You can download a copy and get that in your office. GlaxoSmithKline has one also available on a nice hard copy laminated. So just get familiar with what medications can cause hyposalivary conditions in our patients. I've had a patient who couldn't figure out why she kept getting caries despite what we were doing, and I realized we did actually, there's a test you can, using timing and little cups and things. It's available from GC America. It's called Saliva Check, and it's got really cool laboratory quality litmus paper to see the resting pH. There's a little test for stimulated flow rate. It tests buffering capacity. So it's a nice little diagnostic test to see if your patients have adequate salivary function. And it turned out she was an RN, and her diet was pretty good, and her hygiene was okay. She had a lot of exposed roots, which is a risk factor. But she kept getting these root caries because we realized her saliva was not functioning properly. It just wasn't buffering properly. Her flow rate was decreased. Just like there's of the 5 or 6 different things that this test showed, she failed most of them. So since we've gone back and tested her, and her saliva flow has improved since then. She stopped getting caries. But you don't do this all the time. Every once in a while you'll do this if you can't figure out why a patient still continues to have active dental decay. But usually you can tell when you're doing the saliva check, when a patient comes in and we're doing the exam, how I check for hyposalivation is you're talking to them and you're doing your oral cancer screening. Just look in the floor of their mouth. If it's all shiny and low viscosity, you don't want to see bubbly saliva. You want to see that really watery saliva. And as you're talking, over 10, 15, 20, 30 seconds, half a minute, you'll watch the saliva start to pool in the bottom of the patient's mouth. And that's adequate flow. If it's not, you'll know. We've all looked in a patient's mouth where the cheeks are very dry, the buccal mucosa is desiccated, and we just can spot a dry mouth right away. The saliva is ropey or thick, it doesn't have that low viscosity. So you don't need to be doing checks like this unless you're really kind of perplexed. It's a nice adjunct, but just during the clinical exam as we're looking around, just kind of look in the floor of their mouth and see how fast it's filling up. If you want more information, you can come check those slides and see how fast the saliva flow goes. Deep pits and fissures was a risk factor, as we all kind of know this intuitively. When you look at a patient who's got deep pit and fissure anatomy, it's a prime indication for sealants. That's definitely a risk factor. We get somebody young who's not had a history of a lot of restorative dentistry, and they've got those really deep occlusal pits and fissures, then yeah, you want to mark that box. That deep pit and fissure anatomy is indeed a risk factor. I use a scale. This was generated years ago. It's called the ICDOS system, International Caries Detection and Assessment System. So when we're doing our patient intake interview, I'll call it a tooth number. I'll say tooth number 2, occlusal, ICDOS 2 or 3. The dividing line for what gets restorations, clearly tooth number 4, 5, and 6, those are cavitated lesions, and they still just get restorative treatment, minimally invasive, hopefully. But when you get to that between 2 and 3, that's where you want to start looking at you start using high, fluoride varnishes or SDF. Silver diamine fluoride is amazing. It does stain black, but you have to, work with the patients on that one. That's a whole subject in itself. But silver diamine fluoride is definitely recommended. I prefer to use 5% sodium fluoride varnish, frequent varnish applications to get that surface. And of course, a sealant works great. If you use a sealant, of course, that eliminates that deep pit and fissure anatomy right there. So let's try to keep our sealants in mind whenever we're treating our patients. This is about caries classifications. I'll save that. They come up with a system to try to be better. If we're looking at the different changes over time, we should have a better system for recording that. But go check that journal out if you're interested in that. Another risk factor, number 7, recreational drug use. We have to be able to ask our patients candid questions. The reason why this showed up in repeated data analysis was this has a big impact on saliva flow again. Cannabis use, that's a real contributor to dry mouth. Anything that's affecting the saliva. So if a patient is a recreational drug user, and of course, how many people are home watching Tiger King during the thing, we can see the effects of methamphetamine use. Everybody's seen meth mouth before. But yeah, so this is definitely one of the risk factors, and we check that box. Exposed roots. This is an interesting one that made the cut we're evaluating part of the Cambra process is to look at the risk factors and just having exposed roots. And a lot of people have exposed root surfaces. The critical pH for a root is a lot higher, meaning it's easier to have acid damage than it is on enamel. The exposed cementum and dentin layers, you can see those erosions are just caused by acid attack on there. So when a patient comes in as they get older, they've had gingival recession and exposed roots, that is a risk factor. You see a lot more of those class 5 lesions that we've seen in our older patient population. So that's a box to check. If you look in the patient's mouth and they have a lot of generalized exposed roots, you got to check that box. And there's not much you can do about that. You can have periodontal surgery. Most people over age 40 have some gingival recession, I think, but it's pretty rare when you see an adult that's up in their 50s and 60s that don't have a little bit of recession, but it is indeed a risk factor. Like I discussed, the critical pH for root surfaces is significantly higher. It doesn't take a lot of acid damage to impact the exposed root. Number 9 risk factor, orthodontic appliances. So if the patient's got full arch wires, that's a giant plaque trap right there. The recent recommendations is they're consider people in active ortho treatment to be at least at moderate risk. Orthodontic appliances lead to preferential growth of carcinogenic bacteria, and that makes sense. They've got that railroad track in there, and their biofilm will be affected. Any kind of appliances, ortho bite guards, things like that they wear, it changes the bacteria. So now we've looked at the risk factors. Let's look at the protective factors. These are the things that promote remineralization and health. So this is that top graph is the protective factors. Those are the environmental factors or chemical therapy that helps move the caries balance from disease back again. So these are the things that we're going to use for treatment and protection and prevention. So the big 8. Number 1, fluoridated water. If you live in a fluoridated community, you check that box off. So here in Sonoma County, if they're in Healdsburg, we check their address. If they're in Healdsburg or they work in Healdsburg, they have enough in exposure, we check that box. If they're in San Francisco or in the fluoridated parts of Marin County, we check the box. If they live and work in the rest of Sonoma County, they don't get that benefit. So you check to see if they're in a fluoridated community. That's number 1. Number 2, fluoride toothpaste once a day. We ask the patients, how often do you brush your teeth? And we ask with a fluoride toothpaste. You can't just ask them if they're brushing their teeth because a lot of patients are using non-fluoridated toothpaste. They'll get things from Whole Foods or whatever that have no fluoride. They're going fluoride free. And so that does not count as a protective factor. It has to be a fluoride toothpaste. Just any brand will do, but as long as it's just normal fluoride toothpaste. Fluoride toothpaste a second time. So as we said before, there's a big difference between once a day. Once a day is good, twice a day is the objective. And so we've all heard that message repeatedly over and over. Brush your teeth twice a day for 2 minutes with fluoride toothpaste. So that's low risk instructions right there. So that's the third protective factor. Fluoride toothpaste for a second brushing. Another protective factor, 5,000 ppm toothpaste. And so in our office, we do use a lot of 5,000 ppm toothpaste. We prescribe that. If your patient is currently using 5,000 ppm, you check that box. They get that protective factor. Protective factor number 5, have you had a fluoride varnish applied within the last 6 months? And talking to the reps who bring products, I ask them, in a pediatric dental practice, yeah, fluoride varnish is pretty common, but you don't see it a lot in adult offices. I think that's starting to change. As I talk to clinicians, yeah, they're starting to get on board. Kaiser, it's so well known, the protective impact of applying a 5% sodium fluoride varnish topically, that Kaiser primary care physicians are actually starting to apply it on their patients. They understand the data, and they're helping their patients by doing something that's very quick and easy and effective. So protective factor number 5 is have you had a varnish within the last 6 months? Are you using a fluoride mouthwash, sodium fluoride mouthwash, just plain over-the-counter Act, which is at 0.5% sodium fluoride? That's considered, if they're doing that daily, it's considered a protective factor. Number 7, chlorhexidine rinse daily for 7 days every month. It's not every day. And chlorhexidine, I'll discuss that in a minute. It did make the cut. It is included as a protective factor based on the data that UC produced. The ADA has some contrary indications not contrary, but the use of chlorhexidine is mixed, and I'll explain that in a minute. Actually, I'll just do that right now. So just giving a patient chlorhexidine all by itself will not impact their caries rate, and that's been shown. It does suppress strep mutans and lactobacillus is actually not that much, but it does suppress some of the acid-producing bacteria. And after you stop using it, the bacteria rebound. They'll come back to their present level. If you're doing it in conjunction with remineralization therapy, there was shown to be a therapeutic effect. So just giving somebody chlorhexidine to use won't treat their tooth decay. It's got to be used in conjunction with other therapies. So there's a lot of debate over this. There was the same with xylitol too. Xylitol used to be included in this protective factors, but it's since been dropped down to a recommendation instead of therapeutic because the evidence wasn't strong enough to be persistent in the instructions. So xylitol is just a recommendation, but it's not included as an honest risk protective factor. Number 8, normal salivary function. So typically, vast majority of people do have normal salivary function. There's a few that don't, but in the majority of our patients, you just look in their mouth and you can see their saliva flow is indeed working pretty good. So you just check off the boxes 1, 2, 3, and you add up how many protective factors they have, and that gives you an idea of what's going on as far as remineralization in your patient's mouth. After assessing disease indicators, risk factors, and protective factors, we determine the risk level. So I've been talking about this, and in reality, it takes about a minute to do it when you get good at it. You're just thinking about these things. It's second nature. Your hygienist is thinking about it. Even my patients know, they understand this model pretty good, and they try to keep as much in balance as possible to stay away from having tooth decay. And as you can see from the Delta study, our patients are pretty good at it. You just get a little score. It's not a one-for-one thing. It's just kind of you add up if they've got, that's what the moderate risk group is for. You can clearly tell me if somebody has active tooth decay, they're automatically high risk. You go back and look at biologic risk factors and protective factors, but they're already high risk, and you're just counting the rest of the things up. Where it gets tricky, I mean, low risk, it's obvious too. They're protective factors. They may have 5 protective factors, and their only risk factor is they have exposed roots. Or they're taking a medication that may have xerostomia, but if there's no decay activity and they have a lot of protectors, they're still low risk. Moderate risk is that group in the middle where, maybe they have 3 protective factors and 3 risk factors, and you're kind of not quite sure. It's kind of a catch-all. That's why moderate risk is, when you're first doing caries risk assessment, you tend to put people in that group because you're not quite sure what's going on, but after a while you can recognize high risk and low risk pretty easy, and the moderate risk becomes more obvious as you go on. Again, so to determine the risk level, for a new patient, 1 or more disease indicators, like we said, automatically high risk. For a patient of record, not a new patient, but one of your regular patients, any new disease indicator is an indication of high risk. If you're high risk and you have dry mouth, that's an extreme risk patient. Even if there's no active disease indicators, the patient still can be high risk if they have they have the risk factors greatly outweigh the protective factors and or hyposalivation is present. If there are no disease indicators and few or no risk factors and the protective factors prevail, then they're low risk. And like I said, that's pretty obvious. We know who our patients are that are healthy. They've got good enamel. They don't have active caries. Their diet is good. Their mechanical hygiene is good. And they get the gold star. They're our low risk patients, so we want to keep them that way. Moderate risk, and this is the tricky one. If you're not high or extreme risk and there is doubt about low risk, you might have more risk factors than protective factors, that's moderate risk. Now, it might be somebody, like I said again, they're in ortho treatment, they've got high biofilm, you can see the visible plaque, they're not brushing twice a day, etc. Even if they don't have caries, you may want to put them at moderate risk just automatically because their risk factors are greater than their protective factors. CDT code, so this is, like I said, this is what we do at our office. The documentation, low risk, it's 0601 for low risk, moderate is 602, and high risk is 603. So like we said earlier, Delta does track these, and that's how they generated the study on our patients, and they're looking at you guys too as well. What about kids? We're going to go back now. We've been talking about adults from age 0 to 5. They have different protective and risk factors. You can go back in your journal and see these as well. I recommend looking at that too. And it's a simpler version of what the adult is. But the same thing, you're going to repeat that process. You're going to go look at protective factors, risk factors, and disease indicators. There are multiple caries risk assessment systems. I'm talking today predominantly about Cambra. The reason why I do is because Cambra they've done multiple studies. There's one out of Sweden called the Cariogram. It's also a risk assessment tool that's used widely in Europe. And it is also evidence-based, and it's pretty good. It has some good efficacy behind it. But the original research behind the Cambra one has been studied multiple times in multiple studies. It is really well established. So a lot of other organizations like the American Academy of Pediatric Dentistry and the ADA, a lot of their recommendations for caries risk assessment tools are all based on the original Cambra studies that UCSF done years before. There's some automated things. There's Previsor that Delta's trying to use currently. And then, of course, my startup, my new enamel, we have another risk assessment tool on there. But these are all risk assessment tools that exist to kind of give you an idea of how to assess what your patients are doing. Here's the form. You can go on the American Dental Association, the ADA website, if you just want to download a tool to get started. It's better if you can incorporate this into your own paperwork, because a separate standalone is just, it gives you a way to organize your thoughts, but it's much better if you can just put it into your own paperwork like we have done, or just if you have a paperless office, then build in the risk assessment tools. They should be nice if they came that way, but hopefully we can start to do things to get that incorporated so it's built into the EagleSoft or Dentrix or whatever form you're using. Let's say lowering risk factors. So we try to counsel our patients. I say the easiest thing you do is just start with sugar. Try not to eat the all-day sugar. We talk about the diet, reducing the demineralization. There's some things, these are from our local county that we have cavity-free Sonoma. I got this from Kim Caldaway. These are recommendations for snacks and things like that. I hit on xylitol before. In the original Cambra recommendations, and even in the study, they were looking at the role of xylitol in caries reduction. Xylitol is a sugar alcohol, and in the original Cambra recommendations, they were having patients use from 5 to 10 grams throughout the day. And the recommendation now has been dropped out because it was mixed results. When you ingest xylitol, the biofilm breaks it down, but it doesn't produce acids. You can't produce lactic acid from it, and so it's sort of starving your plaque. You were ingesting the xylitol, and the biofilm wasn't able to generate acid, and it did inhibit caries activity in some studies. So there's some research that shows it's helpful. So I tell patients, after a meal, you go ahead and chew some xylitol gum if you like. A lot of people don't like fluoride. They're all over the xylitol, and that's fine. It's not harmful, except in, but the one recommendation is keep it away from a dog. Your dogs it's poisonous to dogs. You can't ingest, they don't want to ingest it for a pet. So as long as you're using it, not Fido, then you should be okay. And we do chew a lot of xylitol gum because it tastes good. So I tell patients, any sugar-free gum, you're going to stimulate saliva flow. After a meal, your mouth is acidic from anywhere from 30 minutes to, depends on how old you are, if you're taking medications. But the acids are cleared and the pH comes back up. If you pop a piece of sugar-free gum and chew it, the increased saliva flow, you go into a stimulated flow, and the acids are buffered much quicker, so your mouth is only acidic for maybe 10 or 15 minutes instead of a half hour or 40 minutes. There's much less damage being done if you chew sugar-free gum after a meal. Again, start with sugar. UCSF has sugar science. There's a lot of resources there. There's posters, if you want to get into having kids get away from sugar-sweetened beverages. Like I said before, oral hygiene has not gone away. It's still important. Patients, we want to stress, brush twice a day for 2 minutes with fluoride toothpaste. And, Bass technique, all that stuff still applies. The good hygiene is good hygiene. We can't get away from that. We want them to, our patients, if a patient is just all focused on oral plaque removal, that's good. But they can be missing several key items of remineralization, I'll explain why, and still have active caries even though their hygiene's pretty good. So we want to add that one thing, it's clean your teeth and remineralize, and that's what our patients have gotten so good at. If you're flossing, you're doing all these things that you're supposed to do for good hygiene, using interdental devices, water pick, oral rinses, etc. All those things our local periodontists recommend for controlling periodontal disease. Do it before you brush. It's really important to stress that toothpaste is always the last step, because if you think about it, we want to put something in there. It's a therapy, and the analogy I use for my patients is the toothpaste is last. Think about it, when you're washing your face, if you're going to put a sunblock on, you do that last. You don't put your sunblock on and then wash your face. And when I tell it to patients, they're like, oh yeah. So I said, think of your toothpaste as a therapy. You want to put it on and just leave it on, and don't interrupt that remineralization process. The type of toothbrush didn't matter. I tell patients, look, if you're good with a manual brush, great. You get a good plaque control with that, that's fine. Just change it every 3 months. If you'd like an electric brush, there's some studies that show it's better efficacy for plaque removal. So go for it. Electric toothbrush is fine. And then I try to avoid overemphasis on mechanical hygiene. So a lot of times we're beating our patients up because, oh, you missed a spot, you're a little plaquey here and that sort of thing. But it's more about just giving them the guidelines that they can actually follow, that they're actually going to implement and see the improvement. So we don't beat them up too much about that, but it is important. So do good hygiene, but the patient should understand how to remineralize. Dry mouth. So we talked about this a lot. Let's go through this. There's some conditions like Sjogren's syndrome, scleroderma, et cetera. They're automatically, with autoimmune conditions, they're going to have less saliva. Caffeine, alcohol, those are all things that lower saliva function. Number one reason for dry mouth is medications, like we said. Toothpaste with pyrophosphates, tartar-controlled toothpaste, I was never a real big fan of those, and it turns out things like that can also contribute to hyposalivation. So stay hydrated. I just tell patients, make sure you're drinking plenty of water. Appliances, again, that if a patient is wearing ortho appliances, retainers, etc., that's just going to be a little jungle gym for their biofilm. Proper oral hygiene is still important. Maintain the prosthetics. If you've got a partial denture, I mean, some people's partials look immaculate. Other times they come in and they are pretty gloppy. Stay hydrated, so saliva. These are all just some more tips. Okay, we want to increase the protective factors. Fluoridated water, well, you know, we're working on that one. Stay tuned. Once again, stress the brushing teeth once a day with fluoride toothpaste is a starting point. The objective is to hit twice a day, or, you know, we don't recommend much more than that. You don't want to overbrush, but twice a day with fluoride toothpaste. If the patient is at a higher risk, if they're moderate or high risk, we put them on 5,000 ppm toothpaste until they drop down in the risk continuum. Fluoride varnishes. I've been using fluoride varnish even for every 6 months on the low risk patients. I think that's why my patients aren't in that 24%. UCSF saw that their low-risk patients, 24% of them had a risk of having a cavity within the next year. And I don't see that on my patients because I'm hitting them with fluoride varnish. It's cheap, it's easy to do. And even Dr. Featherstone, and I was talking with some other researchers, they're looking at that recommendation. They think that actually might be the next recommendation that comes out in the newest versions of the instructions to really kind of push that bar forward and get that number down. We want to see, you know, we want to get as close to 0 cavities as possible. So also the use of SDF, silver diamine fluoride, prophylactically, especially for kids, putting it on the occlusal surfaces before caries lesions really get started. So either SDF or fluoride varnish. And to me, the varnish is a no-brainer because there's no staining and the efficacy is pretty close to the SDF. SDF is slightly better, but there's a lot of things that go with it. So we get pretty good results just using sodium fluoride varnish topically. Acridents is still good. If low-risk patients don't need this thing, we try to keep it as simple. We don't want to burden the patient with expenses and things they don't need. So if you're up in an elevator, if you're moderate or high risk, yeah, you're going to use more things in the protocol. But if you're just a low-risk patient, you just need over-the-counter fluoride toothpaste twice a day for 2 minutes, and that's your home care routine, and we'll supplement it in our office with some varnish. Number 7, SDF, like I said, there's a lot of research going on. That's a big area, so stay tuned. Follow the developments on SDF in regards to Cambra and minimally invasive dentistry and non-restorative. CDT codes for this stuff. So we do this one frequently. Topical fluoride application of varnish is D1206, and the interim caries arresting medicament, that's for silver diamine fluoride. The CDT code is D1354. So those are the CDT codes. You see how they're in the 1,000. That's why you see that cello shape on my CDT codes, because we're doing this constantly. Maximizing remineralization. So now we're going to talk about, you know, treating caries without a drill. So like we said, we always use fluoride. It's always the last product applied in your home care routine. That's I'm going to put a pitch in for Sonoma County does the caries assessments for kids in the kindergarten. Kim Callaway in the public health department. They ask for volunteers, for people to go in, and it's a lot of fun. It's easy to do. You go in and you look at kids' mouths, and we check off all the information for county data assessment in the state of California. And if the parents give their consent, we're applying fluoride varnishes, and it's fun. It's I like doing it. So if you're interested, contact Reds, and we'll show you how to volunteer. So fluoride toothpaste, very important. Brushing after meals. We tell patients to avoid brushing after meals. You still hear the advice, brush after every meal. It turns out there's a lot of reasons why not to do that. If the mouth is acidic after a meal, like I say, you have some starches, now your mouth, you drop down into that 4 pH range. When you go in the bathroom too soon before your pH comes back up and you apply your toothpaste and you brush, the hydrated silica, the polishing compounds in toothpaste act as an abrasive, and it physically removes 100 times more tooth structure than if you had waited to brush your teeth when the pH was back up close to 7. And that's been verified. I talked to a toothpaste manufacturer. They go, oh yeah, we've done those studies. So when you're brushing your mouth right after a meal, you're basically sanding away the tooth structure, and the remineralization of the fluoride's not as effective when the mouth is still acidic like that. So it's better. The current guidelines for the American Dental Association is to wait 60 minutes after a meal before you brush your teeth. What we tell patients is just when you wake up in the morning, as soon as you crawl out of bed, just turn on the water and brush your teeth, and do a good job and spit out your toothpaste, and try to wait a half hour before you have breakfast or coffee or anything. Then you've got that nice period of remineralization before, and then you do it again right before you go to bed. Avoid rinsing after brushing. So this is kind of interesting. Our patients get a kick out of this, and they share this information with their neighbors, because we advise the following: no food or drink for 30 minutes after you brush, except for kids who can't effectively spit. When it's a little kid, yeah, they're instructed to go ahead and use some water to rinse it out, because again, this is about the topical use of fluoride, not ingesting it. So, so we tell patients, after you brush your teeth, you got a big mouthful of spit and toothpaste, spit it out, double spit, triple spit, everything you can out, and then turn on the water, wash your brush thoroughly, and splash some water on your lips to get the toothpaste foam off. But don't take a big slug of water. People, they'll usually, there's a glass in the bathroom, and I used to do this too. You would fill it up and you'd swish it around and spit it all out and run it again, because you get that big minty blast. Or people use mouthwash afterward. Don't do that. Spit your toothpaste out, spit it all out. Don't swallow it, spit it out, and then just walk away. Just let the actually go to work for you, and you just effectively, by orders of magnitude, increase the remineralization. So our patients have gotten pretty good at this, and they know this, and that's why, like I said, you don't see a lot of active decay in our regular patients. Sealants, again, there's covered the clever story that's recommended in the JADA that came out in October, then again way back in 2010. Sealants are efficacious. We should be using them. Antimicrobial therapy, like I said, the chlorhexidine, if you're high risk, we still do this. I kind of, unless a patient's really, if a patient's plaquey, yeah, we definitely send them home with chlorhexidine. The prescription instructions are rinse for 1 minute, once a day for 1 week each month. They're only doing it for a week. If you do it all the time, you're going to see increase in chlorhexidine stains. We don't want to see chlorhexidine stains. It will lower the biofilm. And so we do this. There's systematic reviews and stuff like that, but it's, the evidence for chlorhexidine exists. It's just kind of controversial right now. All by itself, like I said, it's proven to be not very effective in caries, but it does help for our high-risk patients to kind of treat the biofilm, lower that level. Like I said, discuss staining possibility ahead of time. You want to tell the patient ahead of time, because when they come in with that stain, you got to take it off, but you want to warn them. We've experimented, carie-free has the CDX, the treatment risk. It's hypochlorite based. It's basically minty swimming pool water is how we describe it to the patient. It's flavored, but it's really very chlorine flavored. And so there's no clinical trial. We've used this stuff. When you rinse with it, you can feel your mouth. That plaque goes away. There's other ones being developed, but nothing really currently available other than the chlorhexidine at this time. So treatment rinse is kind of fun to play. We do this once in a while for patients that are just super plaquey and they can't seem to be able to get that biofilm under control. Recommended other therapies, let's see, 6 through adult, extreme. Oh yeah, the MI paste used to be in the original recommendations if you were extreme risk, because if you think about it, if you're missing your saliva, you're missing the repair process that the calcium and phosphate that your saliva carries for remineralization. Your spit is busy repairing your teeth naturally for you between meals. So if a person has lower saliva levels, it was thought that by using a calcium phosphate supplement like MI paste, it would be beneficial. But as the research comes in, it seems like it's not as effective. So the panel most recently provided a recommendation against the use of 10% casein phosphate, amorphous calcium phosphate, which is the ingredients in Recaldent and MI paste. So we don't use very much MI paste anymore. Hardly, I haven't prescribed it at all. It's pretty expensive, and the data supporting it is pretty weak. It's really, you want to get the phosphate and the calcium from the patient's saliva. Here we go, therapies, the varnish. Here's what optional for low risk, that's what we do on exposed roots for sensitivity, etc. Moderate risk, 1 or 2 applications at different recalls. You kind of moderate risk, they're going to get double applications for varnish. High risk, they're getting 3 applications spaced out every 3 or 4 month recall. You shorten the recall. And extreme risk, they're getting the same as the high risk group. So you want to increase your fluoride varnish application depending on the risk factors. SDF we use as directed to reverse or arrest caries. A lot of 5,000 ppm toothpaste. For low risk, you just use over-the-counter stuff, but for moderate risk, we do brush twice a day instead of over-the-counter. So you see in some of the Cambra instructions, they use over-the-counter toothpaste in conjunction with rinses, and it was very complicated, so they simplified moderate risk for saying just brush twice a day with 5,000 ppm. That's a simpler protocol than using ACT, rinse, and some other things. So keep it simple, and the patients can follow the instructions better. High risk is, again, brush twice a day with 5,000 ppm, and then brush twice a day also with 5,000 if you're extreme risk. For sodium fluoride, again, you can see there's ACT rinse that you recommend, over-the-counter fluoride, sodium fluoride rinses after meals daily, at least twice a day. And for extreme risk, they can rinse their mouth whenever their mouth feels dry. Let's see, oral recommended therapies. Again, this is for the adults. Is oral hygiene instructions and counseling for all risk categories. We give out printed instructions. You got to give patients something to take home so they can take a look at it later. Let's see. For extreme risk patients, they can use baking soda to neutralize the acids. You mix up 2 teaspoons of baking soda and 8 ounces of water and just kind of swish that throughout the day. Their mouth is on fire. They really need something. And then there's the xylitol recommendations. These are all summarized in the CDA journal, the most recent one that came out in January. So if you want to go back and look at these in detail, it's on page 45. So CDA journal, January 2019, page 45. So this is important now. So here's how do you implement it, and that's really what I want to stress to you guys if you want to start doing this in your office. The role of the dentist. You really should be the leader in the office and get the team on board so that they'll follow you. Christina, my hygienist, she's awesome. The role of the hygienist, they talk to our patients, they're trusted. The patients trust the hygienist, and because she's so good at Cambra, she's really good at giving patients advices on how to stay cavity free. The front office has to know too. They got to understand, how to manage the products, how to bill, how to record everything. So if you do it as a team approach, it's pretty easy. And it doesn't have to be a dentist, doesn't have to be the Cambra champion. Anybody, your dental if you're a hygienist watching this, you can be the Cambra person, but it helps a lot better when the dentist is on board because then everybody's rowing in the same direction. Patient motivation, they talk a lot about that using techniques of motivational interviewing. You try not to ask your patient, do you brush twice a day with fluoride toothpaste? They'll say, yeah, because you just tell them, we ask open-ended questions like when's your favorite time to brush your teeth? And they'll say, oh, morning and night. Then okay, that's 2. But if they just say, oh, I brush in the morning, and then they're quiet, well, or once a day of brushing, they just told you. So you have to kind of learn how to take the data when you're assessing risk factors and things and make sure the patient's not telling you what you want to hear. They're actually telling you what they do. So be cognizant of that. So when the patient understands the goal using that diagram like we talked about, that tug of war, and they get it that it's empowering. They realize, oh, I can control this disease. I'm not just like, oh, I'm going to get cavities for the rest of my life because I have soft teeth like Dr. So-and-so told me. Plus, they can feel it. When a patient's doing Cambra, one of the first things we found out was their teeth were less sensitive. They could feel it right away after about a month or 2. They were saying like, wow, my teeth don't hurt so much anymore. Time management's critical. Like I said, we all try to run small businesses, and we want to be cognizant of, you can't take all day talking about this stuff. You have to be able to do it pretty efficiently. So work it into the workflow. Ease of gathering, like I said, all our Cambra stuff's baked in. When the patients fill out forms, they've already checked all the boxes for us, so to speak. So when it's a new patient, they've already pretty much filled out all the information we need, and we go back and review that with them. So it's integrated. It's not an add-on. And we have a simplified assessment process. Like I said, this takes 30 seconds sometimes in our office because we go back and review, especially if it's a recurring patient. We already know they've got exposed roots. The gums didn't magically grow back, and we check their medications, and we know they're still taking that blood pressure pill that can affect their saliva. So you make the assessment process so fast, it doesn't take very long to do it. You get really good at doing this. Like again, it'd be great if Dentrix or EagleSoft is doing it. If you're doing it on paper and pencil, you can still do it. It just takes longer. So you want to lower the barriers. So number 1, printed or online patient instructions. That's really good. The patient instructions, you want them to understand what they're doing. We like having this stuff in our office. Most of the offices, the other Cambra offices that we keep in touch with, they do it this way too. Because if you just write a prescription, tell somebody to go stand in line at the pharmacy, especially these days, nobody wants to stand in line for things anymore. So they may not do it, but if you send stuff home with the patient, and we're billing them for this stuff, but we record it appropriately. And if you charge a patient for the products, and we try to keep it reasonable, we try to keep the price lower than if they went to the drugstore, they've got some skin in the game, and it's, you're prescribing a medication for their disease. So be sure to bill for products, like I said. The fees convey the importance of the therapy. Written prescription considerations and legal requirements. by law, when you're doing the model that we do, which is direct dispense to the patient, there's a CDT code for that. By law, if the patient doesn't want to get this, but they want to go to the pharmacy, you have to just literally write down a prescription for the patient, and they can take it to the drugstore. That has to be an option that you offer to the patient. That's a legal requirement. And then, of course, again, you want to always write in the charts what the patient was prescribed, because, you know, if we're being physicians of the mouth, then we have to record what we're prescribing. Tailor the delivery of information to match the patient's health literacy level. You know, you want to keep it so that's something that everybody can understand. What is the future? A validated karyogenic bacteria test. Well, someday, yeah, we'll be able to do, just like, you know, rapid COVID testing, we want to be able to do a rapid test to say, yeah, you've got a dysbiosis and your biofilm's all screwed up, but we don't have that quite yet. Improved antimicrobial therapies. It'd be great to have a rinse that we could do to treat the bacteria, but because we constantly feed them sugar and they like making a comeback, that's going to be difficult to do as well. There's some high-tech devices. They're looking at these little tiny biochips that can measure pH levels and Bluetooth the information. I mean, who knows what's going to come down the pike, but right now that's not very practical. There's automated caries risk assessments. Hopefully by today's lecture you'll be confident to just take a stab and start doing it yourself. It's not hard to do. But there's automated CRAs. There's this thing that was developed at UCSF called Cambra. It runs on an iPad. And they were trying to, you know, you could have this and hand it out to the patients in the waiting room, and they would answer the questions and do it for you. But most of the time, if you just have it incorporated into your own management, your own paperwork, you can do it yourself. It's not, you don't need a computer to do it. The website, New Enamel, you're welcome to go play if you want to go on newenamel.com. There's a caries risk assessment tool, and you got to play with the answers. And you could take caries risk assessment on the algorithm I designed, and you can see it tells you high, medium, and low. You don't have to buy a kit, obviously. But yeah, that way, and what we were doing is we were packaging up kits and prescribing them only in the state of California. So we did this as sort of a test to see what's possible. And we've shipped a few kits out to patients. Several, you know, people all over the state of California are doing this remotely. I'm not their primary care dentist, but they are doing new enamel. They're doing Cambra at home, so to speak. We call it Cambra in a box. But if you want to play with a risk assessment algorithm, you can go on newenamel.com. Let's see, what else is the future? Here's the big one. I mean, we got to get paid, especially now with limited resources. This is never more important than ever. But right now, dental insurance companies, the adoption of the medical model of care, we want to see them adopt that, not just surgical repair. Right now, the more you drill, the more you get paid. And that's just how the model is. But right now, they really are looking at the metric of how physicians are. A physician in medical insurance, they look at outcomes, and they know who the clinicians are that are able to take their patient population and keep them healthy, and that's how the physicians are reimbursed and they're monitored, and that's coming for us. I know with the age of data now, they're going to see which offices are using that utilization codes, who's doing preventive dentistry and who's not, and so there's a day coming where the pressure is going to be great that we can do this. So the model right now has to change. It doesn't exist right now. Continuing education requirements, we take infection control and the dental law, that's important, but caries management by risk assessment is not a requirement right now. That'd be great if it was. Litigation pressure, like I said, dentists are being sued for not doing this. In public health, I mean, Dr. Kumar, the state dental director, is a firm believer in caries risk assessment. They do that for different counties and states, and he understands the power and the importance of getting caries risk assessment and early management to improve the standard of care. And greater adoption just because the public here, most people don't walk in saying, hey, are you one of those Cambra dentists? I mean, my patients do when they move out of the area. They asked me, they said, hey, I've had, I really like the style of treatment we get here. Do you know of another dentist? I'm moving over to X, Y, or Z. Do you know of somebody there? And usually I know some of the other dentists in the area who are Cambra dentists as well, and we all kind of talk to each other. But it's hard. You just tell the patient, make sure that your dentist is, don't tell them don't drill unless there's actually a hole there. If it's there, you got to kind of push back if you're the patient to say, what happens? Can I do? Is there an alternative to me getting this filling or getting this crown? What happens if I do this instead? But the population as a whole, they don't demand this yet. The future of Cambra, like I said, the world has changed because of the COVID virus. The implications are dental care will be greatly impacted. I mean, we've yet to see what's going to be going forward. Cambra is important, but right now we've got to deal with the fire that's burning. So clearly, we've got a lot on our plate to handle. So we'll see what the future brings. So most importantly, my advice to you is just go ahead and start doing it. It's fun, and like I said, it's really rewarding. So, and your patients like it too. So hopefully you've learned something. I've had fun presenting, and there's a quiz involved, so I hope you guys do pretty well, but stay safe. Keep your distance. We put Martin out in the parking lot. Oh, I'd like to thank our Executive Director, Martin Van Tassel, for doing a great job. And thank you for attending. We had fun presenting. Stay safe.